Good evening, everyone. I am very happy to be hosting EAM's webinar in obstetric airway management. This evening, we are happy to be joined by Professor Mary Mushambi from Leicester, UK, as a lecturer, and also by Professor Eric Uten from Toronto, Canada. Welcome, good evening. Also moderating with me is Professor Robert Greif from the University of Bern in Switzerland, and Dr. Sabine Nabeker from Toronto, Canada. And now to you, Sabine.
Okay, welcome everyone. My name is Sabine. I'm situated right now in Toronto, Canada, and I'm an anesthesiologist, and I want to introduce you quickly to today's topic. We have a very exciting webinar planned ahead on the topic of airway management in obstetric patients. And as you all know, there is still a high incidence of failed intubation for obstetric patients, and there are other factors in airway management to consider for obstetric patients. So we are very happy to have Mary and Eric telling us a bit about updates and controversies in obstetric anesthesia in the airway management, as well as what is new in this topic. Now, I'll hand over to you, Tino, to tell the audience a little bit about how this webinar is going to work.
So welcome again from Switzerland. My name is Robert Greif. I will explain shortly how this webinar works. We have two presenters. There are some surveys in between to have an interaction with you. You can answer this. We will show the results immediately thereafter. If you have a question, please use the Q&A function of the Zoom. We will then in between and at the end have a round for answering the questions. The chat function is for you. We will not attend the chat function. It's too cumbersome to look at all the different comments. So important, use the Q&A function for your questions. In case we cannot cover all the questions, we will summarize them, and you might have the possibility to see a short articles on this question in the EAMS journal, Trends of Anesthesia and Critical Care. Another point, we will record this webinar, and the members of the society can then afterwards watch it in the protected area. So it's for members free in a couple of days on the web page. And with any further ado, I hand over to Paula for introducing the first speaker.
Thank you, Tino. I will now introduce Professor Mary Mushambi, who is a honorary consultant anesthetist and assistant medical director from the Appraisal and Revalidation Lead University Hospital of Leicester, UK. She's also DAS Professor of Airway Management and author of the DAS Guidelines in Obstetric Anesthesia. Welcome, Mary. Thanks for joining us. She will now enlighten us on the controversies and updates of airway management in obstetric patients.
Thank you very much. I hope you can hear me and see my slides. Is that okay?
Yes.
Yeah, you can see that. Fantastic.
Yes.
Thank you very much to Paula, Tino, and Sabine, and Eames for inviting me to speak today on obstetric airway management. So greetings from Leicester. This is my hospital in Leicester, the Leicester Infirmary, and we have a unit which delivers 7,000 deliveries a year, so it's quite a busy tertiary referral centre. So my plan today is to look at three things. I'm going to look at rapid sequence induction and extubation in the obstetric patient to see how can we address safety issues and improve patient safety. And then I'm going to look at anticipated difficult airway in the pregnant woman. And then finally, I'm going to look at a controversial topic, which is the use of a supraglottic airway device as a primary airway device for cesarean sections. So starting off with the rapid sequence induction in obstetric, this is the safe obstetric general anesthetic algorithm that we put into the guidelines. And the reason we put this was really to try and standardize the obstetric general anesthetic, to try and modernize the obstetric general anesthetic. And it's a really useful tool, teaching tool, because it addresses both technical skills and non-technical skills such as teamwork, communication, planning, and decision-making. Now, the reason we really are pushing education is because when we look at the morbidity and mortality statistics of the obstetric patients, there's no doubt at all that the outcome of the obstetric patient is far worse when compared with the general population. For example, the chances of an obstetric woman becoming hypoxic during rapid sequence induction is about 10%, not a good percentage. We know already that the incidence of failed intubation is high. We also know that the chances of needing a front of neck in obstetrics is higher. And if you fail to intubate, that chance is 1 in 60. We know that the chance of a pregnant woman dying at an obstetric general anesthetic is higher. And if you fail to intubate, that chance is 1%. And from NAP5, we know that the incidence of awareness in obstetrics is also significantly higher. Now, if we take this a step further and look at what happens to the obstetric woman if we have a failed intubation compared to an obstetric patient that doesn't have a failed intubation, you can see again here, the chances of that woman becoming hypoxic is really high compared to an uneventful general anesthetic. And the lowest maternal oxygen saturation is 40% compared to 84%. We know incidence of fail of aspiration is higher, and the chances of that baby requiring neonatal unit is also higher. So these are the reasons really that we need to address how we perform obstetric rapid sequence induction and general anesthetic. So let's go back to the algorithm, the safe obstetric general anesthetic algorithm, and look at it in a little bit more detail. So if we start at the top there with the pre-theatre planning and preparation, I'm not going to look at every item on this. I'm just going to focus on some of these, starting off with the intrauterine fetal resuscitation. Now, the reason this is important is because in those incidents of a fetal distress, if we carry out these simple measures, we can improve placental blood flow, and therefore it might allow us to buy time to reduce the panic and prevent possibly the need for a general anesthetic. If we look at another item, which is the use of checklist. Now we know that the WHO safety checklist is now used universally. And it improves patient safety. Now, if we take this a step further and have an obstetric rapid sequence induction checklist, such as this, which we have in our hospital, the good thing about this is that it addresses patient preparation, equipment, drugs, and difficulty. The principles of this is that we use it when you're pre-oxygenating the patient and your assistant asks the anaesthetist these questions, such as when preparing the patient, is your cannula working? Have you remembered to give your antacid? And equipment, is your suction switched on and under the pillow? Have you got the drugs ready which are appropriate for that patient's weight? Have you prepared if you have a difficult airway? What is your plan B? What is your plan D? And if you fail to intubate, are you going to proceed with surgery, or are you going to wake up this woman? And to do that, we know that we go and use the table 1 of the difficult airway guidelines, where we know that 7 of the 9 factors that we need to consider in that decision are there before you put this patient to sleep. So start that process before you put the patient to sleep. Now, I appreciate in an elective setting, it's very easy. You've got time to discuss with your surgeons, but in a category 1 cesarean section, you may not have time, but it's still important to do a mental plan in your mind of what you're going to do. Because if you have the unfortunate incidence of a failed intubation, then by the time that happens, it's going to be a stressful time, and there are going to be human factors, situational awareness kicking in. You're going to be really high cognitive load. So try and do that, some of that decision making before you put the patient to sleep. Now let's move on to the rapid sequence induction, and what can we do there to try and prevent the woman becoming hypoxic? And the things we can do are changing the positioning, make sure the patient is head up when you put them to sleep. Oxygenation techniques, apnic oxygenation techniques, the drugs we use, mask ventilation, and your choice of laryngoscope. Now, I know Eric is going to be covering on some of these, so I'm only going to touch on these very, very briefly. Starting off with mask pre-oxygenation. The teaching is that we pre-oxygenate to an end tidal oxygen of 90%. However, we know that half the time we don't achieve it. And also, as I stated in one of my earlier slides, 10% of the time, our women are still desaturating to less than 90%. So we need something to do more than just pre-oxygenating our patients, which takes us to the apnic oxygenation techniques, which you can do using a nasal cannula with a low flow up to 15 liters per minute. And this is all included now in this algorithm. And of course, we can also use high flow nasal oxygenation. And of course, we now fortunately have this evidence from this paper published in the European Journal of Anaesthesia, where they did blood gases post-intubation comparing high flow nasal oxygenation and face mask, and showed that we can now say high flow nasal oxygenation is a safe method of oxygenating. And note we're saying oxygenation, not pre-oxygenating, because we're looking at peri-intubation oxygenation. What about mask ventilation? Well, historically, we've always discouraged this because we were worried about gastric insufflation. But now we know that if you limit the peak inspiratory pressures to 20 centimeters of water and you've got cricot pressure applied, you don't get that gastric insufflation. And therefore, we have included in the guidelines, you can use gentle mask ventilation. And it's interesting, in the UK, the numbers have now gone up. Nearly 80% of people are now starting to mask ventilate during rapid sequence induction in obstetrics. It's quite promising. What about induction agents and looking at the debate between propofol and thiopentone? To be honest, as far as I'm concerned, there's no debate because of all these advantages of propofol that are listed here. What surprises me is that when we do surveys in the UK and in France, nearly 70% of anaesthetists are still using thiopentone in obstetrics. I'm not sure why. We're not changing practice. Now, while still at the topic of induction agents, we mustn't forget one of the recommendations of NAP5, that we must always have an additional second syringe of your induction agent in case you have a difficult airway, in order to prevent awareness during a difficult intubation. What about muscle relaxants, where the debate between succinylcholine and rocuronium, I'm afraid, will still be ongoing for a bit longer than the propofol debate. And this is reflected in that 92% of anaesthetists in the UK are still using succinylcholine for rapid sequence induction in obstetrics. And the reasons may be listed here. It may be that the pros and cons of sux and roc probably balance each other. If you look at some of these, anaphylaxis, the incidence of anaphylaxis is the highest with succinylcholine, but the severity is worse with rocuronium. Dose calculation, succinylcholine, easy to calculate the dose, total body weight, milligrams per kilogram. With rocuronium, you have to use ideal body weight, lean body mass. Can you imagine rushing down that corridor with a high BMI patient and you don't know how much they weigh and you're trying to calculate that? If you use rocuronium, the high dose rocuronium for a rapid sequence induction, there's no way you can reverse that with neostigmine at the end of 30 minutes, 45 minutes cesarean section. So you have to use Sugamadex, and this has cost implications. And in fact, in our hospital, we're not allowed to use Sugamadex routinely because of the price. If you use succinylcholine and you have a failed intubation, well, the worst thing is that when you're trying to manipulate that airway, that's when your sux is going to be wearing off and you end up with laryngeal spasm, which is not a good thing when you've just had a failed intubation. And this is where rocuronium has really an added advantage. And personally, I really like rocuronium. So with that, I think we're going to have our first poll questions to ask you all. And hopefully this will be put onto the screen now. Could we have the poll questions? Yeah, so the first one, and you're able to say yes or no. So the first one is, do you carry out mask ventilation during rapid sequence induction in obstetrics? The second one, do you routinely use sodium thiopental for rapid sequence induction in obstetrics? And lastly, do you routinely use rocuronium for rapid sequence in obstetrics? So if you can all answer the questions, and hopefully we'll have the results soon. Okay, so interesting. So 61% do mask ventilation. Good, I like that. Hopefully should be higher than that, should be getting to the 100%. Sodium thiopental, yes. So majority are not using thiopental, so 81% are not using it. And rocuronium, oh, that's interesting. 45% are using it and 55% are not using it. So interesting, interesting. Okay, good. So we're going to continue my talk. So I'm going to now talk about extubation. Now for this, I'm not going to be looking at the DAS extubation guidelines. What I want to focus on is extubating that obstetric patient in the obstetric theatres. The reason being, in obstetrics, majority of our patients are awake, and therefore the theatre environment are much more used to a patient who's awake at the end of surgery. But we need to start teaching them that things can go wrong about extubation. And the reason I'm bringing this is of a case that we had in our hospital, which I'll share with you now. So this was in the middle of the night. A lady needed an emergency cesarean section. Anaesthetic was straightforward until the end. Patient was breathing spontaneously after reversal and obeying commands, was extubated, at which point she started clenching her teeth and started desaturating very, very rapidly to the point where she needed reintubation. Post-intubation, patient had a cardiac arrest, which was managed successfully with a good outcome. Now, I don't want to focus on the cardiac arrest. What I want to concentrate on is this period. What do you think was going on in the operating theatre when the anaesthetist was starting to reverse the patient with the patient and extubating the patient, and when things were starting to go wrong? This is what was going on. Multiple distractions. There was noise in the theatre. The theatre team were cleaning the floors, packing the instruments away, shouting sign out. Now, we can't blame the theatre team for doing that. The reason is we need to teach them. We spend a lot of time teaching about failed intubation, difficult intubation. We don't focus on teaching about difficult extubation, failed extubation. And we need to try and use every general anaesthetic as a teaching opportunity and use debriefing tools, which can be done either at the end of the case, at the end of the session, or at the end of the day, to try and include multidisciplinary teaching. Absolutely crucial. Now I'm going to move on to the second part of my talk, which is looking at anticipated difficult airway in the pregnant woman. The reason I'm doing this is because we published this article earlier on, which we looked at the review article of all the published cases of pregnant women with a difficult airway. And what we found, which was really interesting, was that the technical skills required to look after pregnant women with a difficult airway are very similar to the non-pregnant patient. What is different is the decision-making process. The decision of, you've got this woman with a difficult airway. Are you going to allow her to labor and accept that you may have to address the airway problem in the middle of the night for a category 1 cesarean section? Or are you going to bail out and go for an elective cesarean section? If you go for a cesarean section, are you going to do it under regional anaesthetic, accepting there's small chance that you may need to put that patient to sleep intraoperatively with a difficult airway? Or do you bail out and go for a general anaesthetic? You also have the unpredictability of delivering that child, which can be at any gestation, preterm, term, post-term, at any time of day or night. and any grade of cesarean section from a category 4 to a category 1. And then you can also have obstetric related pathologies such as preeclampsia, which can impact on an already difficult airway. And then, of course, you've got the baby to think about. And particularly, mothers may refuse treatment because they don't want the impact of the treatment of that airway on their baby. And therefore, with this all in mind, the focus of our paper was to give guidance on this decision-making process. So we have a decision aid, an overview of how we approach a pregnant woman with a difficult airway, and then how to make that decision about allowing the woman to go to labor or for an elective cesarean section. And I'll look at this in a little bit more detail. But before I do that, I just want to share with you examples of the type of cases that I'm really talking about. So the first is women with congenital conditions, such as this Klippel-Feil syndrome. This was a large proportion of the women that we saw that were in the cases with the anticipated difficult airway. And there was a general principle with these patients is that a lot of them would have a difficult airway as well as a difficult back. So there'll be a difficult intubation and a difficult regional anesthetic. So two things to struggle with. Morbid obesity, a huge problem. At what BMI would you feel comfortable to allow the woman to labor and be able to face them in the middle of the night? Or would you bail out for elective cesarean section, as we did with this woman with a BMI of 74 and weight over 200 kilograms? Women refusing treatment. This was a woman who had Hodgkin's lymphoma, which was diagnosed in the first trimester. And when she was offered treatment, she refused treatment. In fact, she refused follow-up and didn't come for follow-up until at 33 weeks, when she was presented to us with stridor and a difficult airway and struggling to breathe. And we had to deliver her, and she was still refusing treatment. So we ended up delivering her at a cardiothoracic center with cardiac bypass all ready and set up ready. Obstetric pathology impacting on a difficult airway. This was a patient who had multiple seizures from an eclamptic fit, had bitten her tongue, and this is what her airway looked like. And on top of that, she had low platelets. So if you are the anesthetist on call, how do you anesthetize this patient? Well, what they did is they did a spinal anesthetic. But of course, the question arises is, what would you do if she required a general anesthetic intraoperatively? She's got low platelets, so there's a chance she may bleed. What would you do? So these are all the things that you need to address in the planning. So I'm not going to go through how to address a pregnant woman with a difficult airway. So at the top there, we need these patients to be identified by our obstetrics and midwifery colleagues, because they see all the patients, and then they send them to us so we can review them in our clinics, where we then do an airway assessment and decide, do we need to send them for a multidisciplinary meeting discussion, where we then plan mode of delivery, timing of delivery, and even perhaps sometimes place of delivery. You may then decide you're going to allow this woman to labor, or you're going to go for an elective cesarean section. If you go for an elective cesarean section, you have to decide, do you go for regional anesthetic or a general anesthetic? If you go for a general anesthetic, you then have to decide, do you do an awake intubation or an asleep airway? Now, the really biggest or most challenging decision is at this stage of either allowing this woman to labor or going for an elective cesarean section. And to help with this, we put together this decision aid 1. It looks a bit busy, but don't worry, I'll talk you through it. It's very simple, actually. So at the top there, you need to ask the question, can safe airway management be achieved out of hours in this woman? And to answer that question, you need to address 3 things. Firstly, the clinical characteristics of that patient, the obstetrics and the anesthetic clinical characteristics of that patient. Then you need to ask yourself, do you have the equipment in your hospital to address this patient or to look after this patient 24 hours a day? Do you have the personnel in your hospital to look after this woman 24 hours a day? And if you think you can deliver safe airway management in this patient out of hours, then by all means, allow the woman to labor. You may then consider, are you going to induce this woman on a specific day so that you have a plan with the team and equipment already? But that labor needs to be actively managed. You want an epidural that's working. You want to make sure you're following the progress of that labor and avoid a category 1 cesarean section. That's really the thing you don't want to have. You want a bit of planning time. If, on the other hand, you think you cannot deliver safe airway management, then go for an elective cesarean section for airway reasons. Now, I can see some of you are probably thinking, can anaesthetists ever really convince the obstetrician that we want an elective cesarean section for airway reasons? Well, I'm going to share with you a case that really illustrates this. So this was a lady who had multiple pterygium syndrome, difficult airway, difficult back, and she'd been seen by obstetricians who were going to go for a vaginal delivery. Fortunately, anaesthetists heard about this in the grapevine, and at 33 weeks, when they heard about it, they asked for a multidisciplinary team discussion, where it was then decided they were going to go for an elective cesarean section for airway reasons. Now, I want to share with you what happened on the day. This is an elective cesarean section. Now, firstly, I want to point out the authors of this paper. I know the authors very well. They are all experienced anaesthetists and experienced airway anaesthetists, obstetric anaesthetists. So this is what happened on the day. They tried a spinal, it failed. They tried oral awake intubation, fiber optic intubation, failed. Nasal, failed. Awake video laryngoscope with a Pentax, it failed. Awake video laryngoscope with the GlideScope failed, and eventually, with different positioning of the patient, they managed to succeed with an awake fiber optic intubation. Now, this is in an elective setting. Could you imagine that had they followed the obstetrician's decision and they were faced with a category 1 cesarean section in the middle of the night? That is not a patient to face in the middle of the night on your own. So coming back, you've made this decision of you're going to go for an elective cesarean section. The next decision is, are you going to go for a regional anaesthetic or a general anaesthetic? Because you need to be aware that if you go for a regional anaesthetic, there is a small chance that either your regional anaesthetic may fail intraoperatively, or you may start having reasons to put this patient to sleep, such as bleeding. So how do you make that decision? Well, I don't have a complete answer for this, but I can give you some suggestions which come in the form of this case report from 1995 by Martin Dresner. And what they did is they used awake laryngoscopy as an airway assessment. So it was a patient with the Klippel-Feil syndrome, a bit similar to my patient here, with a difficult airway and a difficult back. And what they did is they did an awake laryngoscopy, and they used a Macintosh blade. Nowadays, obviously, would use a video laryngoscope under topical anesthesia, and they had a clear view of the glottis. And therefore, they were happy to do this woman under regional anesthetic, knowing that if they needed to give a general anesthetic intraoperatively, they would be able to intubate the patient. Now I'm going to move on to the last part of my talk, which is the controversial part, which is the use of supraglottic airway devices as the primary airway device for cesarean section. Now, I'm not talking about a failed intubation situation. This is a primary airway device. Before I go on, I'm going to ask you all another poll question, and this is hopefully the poll question will come up for you to be able to answer. And the question is, have you used a supraglottic airway device as a primary airway device during general anesthesia for cesarean section? A yes or a no? I shall be very interested to hear what everybody's answer is. Interesting. So we have 13% who've done that. That's interesting. 13% versus 87%. Well, interesting. Interesting. Anyway, I'm not here to say to you guys that you should be doing this, because personally, I don't think we're quite there yet. But the reason I'm bringing it up in my lecture is because there are already enough studies out there to tell us that this is actually going on in some hospitals. So in our review, which we published last year, there were 11 studies, of which 8,000 patients had been studied, but only 4 of those were randomized studies. And to give you some idea of some of the things that are going on, this is what was described in one of the papers, which said that the majority of their cesarean sections were being done under using supraglottic airway device. And quite often it was a patient who were asking for this. And they'd been routinely practicing this for over 5 years. And this was published in 2017. And not only that, they weren't just doing it in patients who were fully starved. They were doing them in category 2 and 3 sections. So patients would only been fasted for minimum of 4 hours. So this is what is going on up there. So let's look at the results from the papers that I mentioned earlier on. What is surprising is that it does appear to be safe to use a supraglottic airway device in these selected patients. There was no case of aspiration. There was only one case of regurgitation, which occurred at the time of applying fundal pressure. And therefore, overall, supraglottic airway device actually is performing, if not better than endotracheal tube. And this has been reinforced in this meta-analysis, which is published around the same time that our paper was published, actually, where they managed to find 14 studies of randomized studies, which I was surprised. In fact, I couldn't find a lot of these papers, and quite rightly, because they said a lot of them were low quality studies. So over 2,000 patients were being studied, and their summary as well was that supraglottic air devices are performing as well as an endotracheal tube. But there's a huge but here. Their conclusion was, despite the success rate, despite the high safety rate, the analysis remains underpowered and therefore inconclusive. And therefore, further studies are still required before we can recommend the use of supraglottic airway devices, because there are still a lot of unanswered questions, such as, is a supraglottic airway device safer than the use of endotracheal tube from an aspiration point of view in pregnant women? How would we select patients if we decide to use it? Would that be based on the BMI or gastric contents? And what is the role of gastric ultrasound? Which is the best device of all these supraglottic airway devices to use in obstetric patients, because they all behave differently? Which is the best anesthetic technique? What do we do with cricoid pressure? And what's the impact on training? Because we would have now to teach a completely new, different technique. I'll leave you to think about that. And I'll finish my lecture. And I hope that I've covered all the things I was going to say. And I'm very happy to answer any questions. Thank you very much. I shall stop sharing my screen. There we are. Thank you.
Thank you, Mary. Excellent talk. We've really learned a lot. Tino, would you like to look if there are questions from the audience?
Thanks, Mary. There are 2 short questions. We still have time. One is asking, what's the experience you have with video laryngoscope, and do you prefer a specific version?
Very interesting. It was in my lecture, actually, and I took it out because I was trying to cut on time. I absolutely recommend video laryngoscopes in obstetrics with no hesitation at all. I use that. And I think also, to be honest with you, it's one of the advantages that COVID had done is that it has forced a lot of people to use video laryngoscopes, certainly in the UK. I think the use of video laryngoscopes has escalated because of COVID. Now, the decision of which is the best one, unfortunately, we don't have that evidence. Part of it being that actually none of the video laryngoscopes have a short handle. They're all long handles, a lot of video, which makes it really difficult in the obstetric patients. However, in principle, what I recommend is that we use a Mac blade video laryngoscopes for 2 reasons. The first one being we are familiar with it. And the second is that with the Mac blade video laryngoscope, You can use both the direct view and the indirect view to intubate, should it be a difficult intubation. So it gives you two options to use that video laryngoscope.
Another question, maybe a short answer, using of awake fiber optic topicalization in obstetric patients.
Yeah. To be honest with you, when we looked at the evidence in all the published papers, there was very little difference between non-obstetrics and obstetric patients, which is what I say. The technical side of it is very similar. The only thing that perhaps one wouldn't do is use things like cocaine. Now, I know most people don't use cocaine anyway, so it's something that we tend to discourage to use in obstetrics because, of course, it causes placental problems. But anything else, to be honest, is very similar to the non-obstetric patient. I would do exactly what I would do in the non-obstetric patients with very little difference. The only other thing is people do try and avoid the nasal tube, nasal passage because of the risk of bleeding. And when I do awake intubation in pregnant women, I've always done that via the oral route. But in the review that we did, there were still patients who were intubated nasally. And occasionally that may be the only route to actually intubate the patient, so you have to do it.
Okay, we will have time after the second presentation for the other questions, and with this I would like to hand over to Sabine for the introduction of our next speaker.
Okay, thank you very much. It's my great pleasure to introduce Dr. Eric Uten, who is an associate professor at Mount Sinai Hospital here in Toronto. He was trained and is currently still working at the University of Toronto, and he is currently also the program director of the Anesthesia Residency Program and the director of the Advanced Airway Management Fellowship Program at the Mount Sinai Hospital here in Toronto. He has published many publications and received numerous research grants on his work, focused predominantly on airway ultrasound, airway simulations, and technical and non-technical performances in airway management. And with this, thank you, Eric, for joining us today, and the floor is yours.
Thank you. Good evening, I think, to most of the audience here. It's the afternoon in Toronto. So thank you for coming. And I'd like to also thank and extend my thank you to the organizers for the invitation. So Paula, Sabine, and Tino, thank you for the invitation, and also the organizers for putting this together. So I also like to thank Mary for providing you some background information, and I think my talk will not overlap, but might be reinforced to what Mary has provided so far. So in no time ado, I will share my screen. And let me know if you see it. If that's good, I will start. So, as Mary has alluded, she has went over some of the controversies of airway management in the obstetrics and pregnant patient. I would like to talk to you about what's new in airway management. In fact, the word what's new is a little bit of semantics. Sometimes what's new is coming from the OR, and what's new sometimes is about optimization in airway management in the pregnant population. And all of you is aware that airway management in pregnant now has been mainly done through regional. And the airway management in pregnant population is about 5 to 7% in most of the cases in different institutions. So what I would do now is to introduce you to our hospital, which is similar to what Mary mentioned. We have about 7,000 deliveries. It is a tertiary obstetrical center. It is the largest one in Canada. It has level 3 NICU, neonatal intensive care unit, with 5 operating rooms dedicated to the obstetrical patients in case room. As Mary mentioned, it's usually a multidisciplinary team. This was the first baby of 2017, and you can see there's multiple caregivers. This is the anesthesiologist of the day. There's a fellow and senior resident, the obstetrician, as well as the several obstetrician team, as well as anesthesia assistant, respiration therapist, neonatologist, and the nurses. So the whole care of obstetrics patients is very multidisciplinary, as in many institutions. And before I move on to my talk, I would share that I have no conflict of interest. So I'd like to focus mainly on airway management in this population. and highlight on two parts of the airway management. One is the anatomical airway, and the second one is the physiological airway, which some of you have already heard of this concept. It was actually coined by emergency physician when they intubate, physiologically critically ill patients. I'm going to focus my talk, as Mary mentioned, a few cases that she, presented. I'll focus on something that is not uncommon at our place because we have a obstetrician who specializes in high BMI pregnant patients. So my case scenario will be then move forward, and bear in mind, this is how I'm going to discuss the case. This is a 35-year-old G1P0 patient at 36-week gestation with a high BMI of above 60, is in labor, and then experiences sudden, sustained, severe fetal bradycardia in the 60s. A category 1 emergency C-section was declared, and airway exam looks typical of a high BMI with a Malampati 4 and a short neck. So what would be the management option from the audience? I'm going to take a pause, and then Sabine is going to read out the question. I'm just interested to see how the audience is going to start with this case.
Yes, you're going to just wait until the poll comes up. So just think about what will be the management option at this point for this case. Will it be either a general or regional approach? Can we have the poll questions, please? Thank you. So from the results, what we can see is 83% Eric voted for regional anesthesia and 17% for general anesthesia.
Okay, that's true. That's good. So I would agree with this. So the management option first is, we talked about a multidisciplinary approach. And something that I recommend is, as we are moving patients to the operating room, before you finalize on your management plan, is to reassess the fetal heart rate, because sometimes it does recover and sometimes it worsens. And so therefore that would affect your decision-making perhaps. Something that you will consider is a simultaneous anesthesia plan, because I agree that we can attempt to do regional, whether it's a spinal or CSC, bearing in mind that this patient with a high BMI would likely be difficult from a lumbar spine, from palpation. Even though you use ultrasound assisted, it can be very challenging. While at the same time, you need to bear in mind that this patient might go down the path of a general anesthesia, and how will you manage this patient in this case? You have a patient with a potential difficult anatomy and physiological challenge. So in this case, you might need to do both. While you're attempting the regional, you might start to plan for your airway management, bearing in fact, both the anatomy and the physiology needs to be managed at the same time from an airway point of view. So what I'll be focusing is on the airway management on this patient. I would say that the spinal has failed. It has been very challenging. Now in the path of the airway management. Why should we care? Well, as you know, these pregnant patients, you have two patients to be concerned about as compared to the non-pregnant population. You do have the mother and the baby to think about and the fetus. And then it's all a healthcare team, because some of the healthcare members will have different priorities, and you might feel pressure in which could affect your management plan. As I mentioned, the first airway management that you have to think about is the anatomical airway of the pregnant patient. And as Mary alluded to, and this is one of the classic study by Kodali that looked at the pregnant airway before laboring and after laboring, and showed that the Malampati and difficulty increases due to edema. As you can see, this is a patient who had a Malampati 1 prior to laboring, and a couple of hours after labor, this patient's airway has changed completely to a Malampati 4, is more edematous, and it's probably more friable and more prone to injury as well. In addition to the pregnancy-related changes in the airway, we always have to think about the high BMI. In this case, in which this patient might not want to have a joint anesthetic because of effect on the baby. You may have a difficult patient cooperation. This patient will be, as you know, because of the high BMI, potentially difficult mask ventilation, difficult laryngoscopy, intubation, and with a short neck is a difficult surgical airway. So you have all of these confounding factors from an anatomical point of view. We can make your airway management needs to be properly planned and executed. So again, it is a balance between the care and safety of two patients. Even though you're faced with a situation of a fetal bradycardia, the physiological changes, in addition to the anatomical change of the airway, is a result, as Mary explained, is the aspiration risk, the rapid desaturation, and the severe hypoxia in very little time. This can happen once a patient is apneic. In addition, you need to balance the fetal placental perfusion to deal with the potential aortic cable compression if it was a patient who was not properly positioned. And as a result, any hemodynamic changes or hypoxia that's felt by the mother can result in fetal hypoxia as well. I won't go too much in detail on this. Mary mentioned this, that the failed intubation in the obstetric population is one of the classic study by Kinsella and group, was about 1 in 5 to 8 times greater. 5 to 8 times greater in the pregnant population. This is further collaborated by Quinn study again in 2013, that the risk of failed intubation in this patient is about 8 times greater. And the risk factor was obesity and advanced age. And in fact, the risk of failed intubation increased 0.7 times for every BMI of 1 that increases. So it is no doubt that the parturient airway is at a greater risk of failed intubation. And that can have a significant consequence of a failed airway, including a failed laryngoscopy, intubation, oxygenation, fetal hypoxia, and then a fatality that can happen to either the mother or to the baby as well. So based on that, when faced with an airway that is potentially difficult and challenging, I think one of the first things perhaps is a change in mentality in approaching these patients is, what is the worst case scenario that we're going to face as anesthesiologists when faced with these kind of patients? Well, I think the worst case scenario is, most of us would probably have guessed, is we can face in a situation where we cannot secure the airway, cannot intubate it, and at the same time we have lost the oxygenation and we cannot oxygenate. So now we're in the path of a surgical airway. And the key here is, we don't want to be facing this situation during an emergency. And even if that happened, is there any way we can mitigate the success with the failure rate and improve the success rate? So there was 2 airway guidelines that suggested and advocated that in this case, identifying the cricothyroid membrane prior to airway manipulation or intubation in anticipation of a difficult airway can reduce the risk of potentially complication. Because one of the reasons for failed cricothyroidotomy and poor outcome from a surgical airway is the inability to identify the cricothyroid membrane. So as you can see here, the ultrasound can be used and is well researched that it can easily identify the cricothyroid membrane as shown here in the yellow. We can do it either in the longitudinal approach or the transverse approach. Again, here you can see it as a hyperechoic structure in both the transverse and in the longitudinal approach. Why is this important? Because we have shown that in the obese parturients, using ultrasound, you can identify the cricothyroid membrane in 100% of the patient. But if you only use palpation, you can only accurately identify it in only 39% of the patients. Michael Christensen has demonstrated in the morbidly obese patient that it is actually a relatively fast technique that you can use. In about 24 seconds, you can identify the cricothyroid membrane in the transverse position. If you use the longitudinal technique, it will take you a bit longer, about 37 seconds. I think this time is adequate as long as you have the ultrasound machine readily in the room. And I think with increasing practice, ultrasound has become more of a routine equipment. And a lot of us are now having ultrasound more and more in the operating room. And it is feasible to have an ultrasound readily available in this kind of situation. In addition, we showed that it doesn't take long to learn to acquire the skill of identifying the crack of thyroid membrane using ultrasound. If you have a short training of about 2 hours and you scan about 14 people, you had 14 scans, you'll be able to acquire the skill. In addition, that skill is retained for up to 3 months. So in anticipation of a worst case scenario, you can prepare and identify the crack of thyroid membrane. In the event that you do have to do a surgical airway, you have an idea where the membrane would be and would improve and increase your chance of a success surgical airway. So that brings me up to the next question. As we know, there's different approach to a front of neck access. And this is a study by Laura Dugan. And interestingly, they had an airway app, and looking at 18-month period, they have allowed many healthcare workers around the world to download the app and to record real clinical cases of a can't intubate, cannot oxygenate situation. They had 104 real cases from 21 countries, in which 82% was performed by non-surgeon, and 64% of these cases are actual cannot intubate, cannot oxygenate, real-life emergencies. So as a pause, I just want to see from the audience, in which Sabine is going to ask you the question in terms of the techniques that you think would be best for the front of neck access. So Sabine, I'll ask you from the audience.
Yes, so we're waiting for the poll to come up. It's there already. So which front of neck access technique was reported in this study to be the most successful in the first attempt in clinical cannot intubate, cannot oxygenate emergencies? And you can see here 5 different options. There are estimation of what do you think was the most successful technique. Give you a couple of seconds to answer that question. Okay, so Eric, we have some results here. So I think with 64% that was voted for the scalpel bougie technique. And then we have 18% for the cannula, 8% for wire guided, and 2 times 5% for tracheostomy and surgical.
Good. I think the audience knows a bit about this paper, and I would agree that from the study, the scalpel bougie technique was the highest in terms of first pass success with an 82%. Out of the 45 attempts, 37 was successful in the first attempt. The cannula was second, and then the surgical was a third one, and then the wire guided with like a Melker kit is about 50%. I put tracheostomy at the last because this is usually performed in an emergency situation, probably not by anesthesiologist, but by a surgeon. So interestingly, based on this study as well, Mary has alluded some of the human factors in the airway guidelines that she presented, that good communication, good teamwork, and the skilled personnel was a positive contributor to a successful fauna in this real-life clinical emergencies. And I want to highlight the skilled personnel because it is important that we are trained in these fauna techniques, not just from a point of technical skill, but also from a point of communication as well. Some of the negative aspect in which contributing to a detriment outcome includes fixation on multiple tracheal intubation. And again, this is interesting. It's a delay in initiating the fauna. And many studies have shown that it is not the actual procedure that is detrimental to the patient. It is actually the delay in performing the procedure that is more detriment. And lastly, as we have heard, it is important to plan. And the failure to plan for failure is a catastrophe for many in these many situations when you don't have a backup plans. Just to remind you, the physiological airway that I briefly mentioned before, both the mom and the fetus. And I think it's important to realize that the physiological airway, as Mary alluded, was that these patients are extremely prone to severe hypoxia and severe rapid desaturation once they become apneic. And as shown in her guidelines, it is important to make sure that the patient is properly positioned. And here, this is a reminder, an old study, that in the true pillow, using a true pillow, you can align the laryngeal and pharyngeal angle so that you can improve your anatomy of the airway and make it easier to do a laryngoscopy and intubation to increase your success. Second, if you don't have a true pillow, you can use a HELP position, which is the head elevated laryngoscopy position, in which you can do a ramp up with multiple pillows. And then you can have the back of your bed, if it's flexible, to go up to about 20% upright. Again, that would increase your anatomy view, your airway anatomy would improve and increase your success for first pass. In addition, it is important to pre-oxygenate these patients due to the fact that once they become apneic, they have an increased risk of rapid desaturation. You want to optimize the oxygen reserve in these patients. And this was a classic study by Nimangada that looked at the different methods of pre-oxygenation. And they have shown that the tidal volume of 3 minutes, you have an end oxygen of 88%. If you don't have much time and you only have 1 minute, you can do 8 deep breaths and you'll have about 87%, which is similar to the 3 minute of a tidal volume. In the event of a case of an obstetrical patient in which you're faced with a category 1 cesarean section, you may have limited time to pre-oxygenate. And in this case, doing 8 deep breaths to ensure the patient has 8 deep breaths at 1 minute might provide you with the optimal end tidal oxygen. However, as Mary mentioned, these are sometimes not done properly, and 50% of these cases, these patients do not do the deep 8 breath within 1 minute. So you got to ensure that this technique is properly performed by the patient. In addition to increase the anatomical airway view by doing a ramp-up position, the ramp-up position also increases the oxygenation by about 23%, will give you a longer time for intubation and airway control and a longer apneic time. So not only the ramp-up is important for the anatomy, but also important for the physiological rapid desaturation. And a talk on pre-oxygenation and apneic oxygenation cannot be without the high flow cannula. And this is a classic paper by Anil Patel, showing that apneic oxygenation can be sustained in patients for as long up to an hour. Even in some obese patients, it is prolonged. Some of the studies at this point in 2019 has shown that to pre-oxygenate a pregnant patient, it is best to do it with a face mask ventilation. The high flow nasal cannula might not be optimal to reach an end tidal of 90%. However, once a patient is asleep and is apneic, I would recommend leaving the high flow oxygenation for apneic oxygenation. And for every 10 kilogram meter square of BMI increase, the expired oxygen decreases by 3%. Again, highlighting the fact that not only do you have to deal with a physiological airway, but you also have to deal with a high BMI, which can affect the physiological airway. So how do we increase our chance of first pass success? I think some of the audience has brought up this question. It is important to have a first pass success, as Mary mentioned, because the faster you can secure the airway, that will minimize the time for rapid desaturation and maternal and fetal hypoxia. The question is, what is the best technique for this? And I think many of you have known that the role of video laryngoscopy has changed many of the approach. This is highlighted from a non-pregnant population analysis by Michael Aziz, looking at rescue technique in a multi-center study, looking over 346,000 direct laryngoscopy intubation. And they have shown that the from 2004 to 2013, they had different rescue device from a video laryngoscopy, the fiber optic, the supraglottic tube exchanger, optical stylet, and the light stylet. And here's a rescue graph that is quite compelling, that from 2004 to 2012, and you can see that the first rescue device is the video laryngoscopy, has gone from about a 30% use to almost like a 85% use. The role of fiber optic has decreased from about 30% to about less than 10% use. That does not imply that the fiber optic intubation should not be part of your skill, because as Mary alluded, there are specific cases where the fiber optic is still very valuable. Again, from that paper, you can see that the video laryngoscopy had the highest success rate of 92%. The failure rate was the lowest at 8%. And with the different types of glide scope, the one that they're all pretty high success rate, except for the air track. In this case, was only 2 attempts, and they had 1 out of 2, which is 50%. And this is a study looking at different laryngoscopy device, video laryngoscopy. This was a simulated difficult airway in which a collar was added to a patient undergoing general anesthetic. And they pretty much have a fairly high first pack success, except for the AP advance, which was the lowest at 37%. Perhaps it's because of the way the device is designed, or that perhaps people is less experienced with it. As you can see, the Stokes CMAC, the video laryngoscopy, was pretty similar to the others like McGrath and King Vision. So what is the evidence of video laryngoscopy in the pregnant patient? Even though we're using it, do we have the evidence to back it up? The reason for that is because the rate of general anesthetic is less than 7%. Do we have enough patient population to do a randomized controlled trial? Well, there was a study that was done by Howell and group in the UK, comparing the direct laryngoscopy and video laryngoscopy in a mixed method systemic review and meta-analysis. They looked at 428 patients in 4 randomized controlled trials. They had observational studies in 9 of them. They had 35 case reports with a total of 100 patients. So looking at these, there's at least over 500 patients in which they looked at in their systemic review. And what they showed was that there's no difference between VL and DL in first pack success and intubation time for non-difficult airway based on the randomized controlled trial. Unfortunately, the study is not power enough to determine difficult airways in patients. So based on the observational studies and case report, they concluded that the role of video laryngoscopy should be a primary choice when difficulty with tracheal intubation is expected, and also as a rescue modality. So in this case report, it was shown that VL was the first choice, and it does improve and rescue difficult airways. So based on that, we would recommend that as many of you have probably experienced, that VL is probably your first choice of rescue or your first device in the anticipated difficult airway. Also, what is the gold standard? We know that in anticipated difficult airway, the gold standard classically has been the awake bronchoscope intubation or awake fiber optic intubation. So what I have here is 2 characters, famous characters. Perhaps some of you like these characters. So there's Yoda from Star Wars, and then there's Thor from God of Thunder. The question I want to ask is, just to bear in mind with the audience, which character you like best? And the reason I say this is, what would you do in a situation? Would you prefer to do an awake fiber optic with an anticipated difficult airway, or would you do an awake video laryngoscopy? And I think Mary mentioned that in her talk. And so the reason I say this is perhaps you will change your mind when I tell you that Yoda will do the fiber optic and that Thor will be doing the video laryngoscopy. So you want to take a poll, Sabine? I'm just curious.
Sure. Can we have the poll question, please? In the meantime, while it comes up, you can have thinking about that question. Which is the gold standard for you of anticipated difficult airway? Is it either the awake bronchoscope intubation or the awake video laryngoscope intubation? give you a couple of seconds to answer that question. The results are coming in. So Eric, we have 59% for the awake bronchoscope intubation as per our audience, and 41 for the awake video laryngoscope intubation.
Okay, good. So I'm just gonna wrap up very soon. This is an editorial that highlights whether we should make the awake video laryngoscopy the primary technique for anticipated difficult airway. Looking at a systematic review that was recently published a couple of years ago, they showed that the awake video laryngoscopy had a faster intubation time of about 45-second difference, and the first batch success and patient satisfaction was no different. More importantly, if you were to achieve competence in video laryngoscopy versus fiber optic, the anesthetist will need 25 intubation versus 1 to 6 intubation in the video laryngoscopy. So if you have less intubation because the general anesthesia and the OB population is less than 5%, you're probably going to retain your skill faster if you do video laryngoscopy. This is the aspiration risk that Mary mentioned. They have a higher rate in the failed intubation, and the NAP4 study demonstrated that aspiration was the leading cause of death. The question is, as Mary, there's no enough evidence to show that second generation airway device should be used as a first device compared to the tracheal tube. As a rescue technique, I think that it still should be within our backup plan. And most of the studies have shown that they have used at least one or more antacid, including ranitidine, metoclopramide, and sodium citrate. So there's insufficient evidence to show to be used as a first device under general anesthesia, because aspiration remains a concern. However, with increasing use of ultrasound, and if you gain expertise in gastric ultrasound, that could also mitigate some of the risks because you can determine the degree of gastric content. Paula, we're going to give you the take-home message. This is a home run way into the stage, and this gentleman there cannot do anything except watch the home run. This will be the take-home message. And I just want to leave you with this. It's important that failing to prepare is preparing to fail. When faced with this situation, keep calm and relax, because if you don't, when you're faced with a hypoxia, your heart rate will go up to about 115, your fine motor control will deteriorate. If your heart rate goes any higher, your complex motor control will deteriorate. And if your heart rate goes even higher, you start to lose your vision. So it is important to get calm and relax. Thank you, and I'll entertain some questions. And this is Toronto, please come visit. It's quite a metropolitan city, bordering the largest lake, one of the largest lakes in the world. Thank you.
Thank you, Eric, for this very interesting and comprehensive talk. And I think Tino has monitored the questions for us.
Yeah, thanks, Eric, again. First, a question maybe for both of you, Eric and also Mary. What about the use of video laryngoscope in combination with bougie? From emergency medicine, we know that this is quite successful. Would you recommend this also for pregnant patients?
Yeah, I think, there's now many hybrid techniques, combination of different techniques, such as what you mentioned is the video laryngoscopy and the bougie. Absolutely. If that would increase your chance of success, I think that is the technique that you can use. In addition, there is a combination of the video laryngoscopy as well as the fiber optic is another way of increasing your success. Because sometimes the airway is still too anterior, and even with a glide scope, it is not sufficient to insert the tube. Seeing the tube, seeing the glottis is one of the steps. The most important step, obviously, is to secure the tube, and sometimes that's difficult even with a video laryngoscopy. So I agree, you can use a bougie technique to increase your chance of inserting the tube as well as a fiber optic if required.
Mary, short answer.
Yeah, I agree with that, actually. I think more with a bougie, with a video laryngoscope. I think in the UK, a bougie is a gold standard for using in obstetrics. So I'll recommend that. The combined technique with the fiber optic scope, I think it's more difficult because you probably need it set up and ready already, and they may not be always easy when you're doing a rapid sequence induction. I've done it with a video laryngoscope and fiber optic. It's a fantastic technique, but I don't know whether it has you can do it in a rapid sequence induction situation, whether you've got the time.
Another interesting question also for both of you. A colleague is asking if there's a difficult airway clinic in your institution where you can send people for assessment. Mary.
Yeah, I can answer that. Well, as far as, and this is in obstetrics, isn't it? Well, we have an anaesthetic clinic for obstetrics. And in that, we see patients either with difficult airway or with any other anesthetic-related pathology. So they will come in, but amongst other patients, not specifically for a difficult airway. But we now have, I think we have a clinic, 2 clinics a week for obstetric patients. I know probably some other countries have more than that. I don't know, but in our unit we have.
Yeah, I will echo what Mary says. We do have it's called the maternal infant program, in which these are difficult patients for any reason.
Yeah.
They get consulted by anesthesiologists once a week. If cases arises, even if they have not seen us, they come on the floor. We do have a multidisciplinary team as well.
Yeah.
That involved with the anesthesia team, if it has to be related to any cardiac, respiratory, and airway, predominantly.
There's another question about the ramping, because most of the data comes from obese patients. Do you have really evidence that is helping in pregnant women?
Yeah, I think, again, I think the reduced general anesthetic, because the regional technique has taken over, we have to extrapolate a lot of the data from the non-pregnant population. I think some of the physiology of the high BMI patients cross over with the pregnant patient. They do have similar decreased reserve because of decreased FRC, for example. However, they may not have the increase in the edema and so on, but nevertheless, they're still challenging in terms of rapid desaturation, difficult airway on top of a edematous airway. So I would still think that the data from the non-pregnant high BMI patient in the ramping would benefit the patient of the pregnant population, regardless.
Question for Mary, this will be the last, and then we switch to the summary. How many cases should somebody do a month in general anesthesia to maintain the skills?
I
the
think
tricky one.
That's a very difficult question. I saw that on the question and I thought I can't answer that. I think it's difficult to have we don't know. I can't tell you, to be honest with you. I would be guessing if I gave you an answer. All I know is that we are getting more de-skilled because we're not doing enough general anesthetics, and it is worrying. And I don't know the answer. I really don't. We try and do simulation to help with keeping the skills. But I don't know. I think the thing is to make sure that people who are doing obstetrics are also doing generalist, where they are still intubating. I worry about people who are just doing obstetric because you're not doing enough general anesthetic cases.
Thanks. And with this, I hand over to Paula for the take-home messages, and Sabine will close the session. Thanks.
Thank you, Tino. Could we have the last slide, please, Oscar? Well, in order to summarize Mary's presentation, the key learning points are teaching of technical skills as well as non-technical skills such as teamwork, communication, planning, and decision-making are vital in order to address morbidity associated with general anesthesia in the pregnant woman. The use of an obstetric rapid sequence induction checklist prior to induction of general anesthesia can help in fostering and ensuring patient equipment and drug preparation, as well as the planning for unanticipated difficulty with the airway. In addition to teaching about difficult and failed intubation, there should also be time devoted to multidisciplinary teaching about difficult or failed extubation of the obstetric patient. Pregnant women with an anticipated difficult airway should be identified correctly and referred to multidisciplinary team discussion for decision about the mode and time of delivery, and a robust plan put in place which takes into account the possibility of an unplanned preterm, out of hours, or a category 1 cesarean delivery. At present, further studies are required before the use of supraglottic airway devices can be recommended as first-line airway device for general anesthesia in an elective cesarean section. Next, please. Oscar, next, please. And now, the take-home message from Eric. In order to prepare for airway management in the obstetrical patient, we need to take into the consideration anatomical factors, such as the identification of the neck landmarks by ultrasound in order to prepare for the front of neck access, to get the materials and equipment at hand for the front of neck access, the scalpel boogie tube technique. The patient should be in the optimal position, which is the HELP. And we should always have video laryngoscopy at hand. Either we are performing awake or asleep intubation. The second generation supraglottic airway devices should be available as rescue devices. And also considering the physiological airway, we need to perform pre-oxygenation, for example, by giving 8 deep breaths in 1 minute. Always remember to give antacid prophylaxis, and the performance of gastric ultrasound may be helpful. Well, in order to conclude, I'd like to thank Mary and Eric for joining us, for sharing your time and expertise with us, and also for your engagement in preparing for the webinar and enthusiasm. Well, thanks the audience also for joining and answering all the polls and providing questions that make the webinar a lot more interesting. Now to you, Sabine.
Okay, thanks again, Mary and Eric, for this interesting talk today. And with this, it's my great pleasure to announce the next webinar. It's going to be the last AMS webinar of this year. And it's going to be on November 17th, so hold the date. And the topic is going to be COVID-19, 2 years with the virus. We're going to have 3 speakers at this webinar. It's going to be Professor Sheila Mitra from India, Professor Anil Patel from the UK, as well as Dr. Karyam El-Boghdadli, also from the UK. And all 3 of them are going to talk about changes in airway management in the ICU and the OR. And there might even be some patient views with the illness on this one as well. So thank you very much for coming today, and we hope to see you again on November 17th for the next and last webinar of 2021.
Thank you.
Thank you. Thank you very much.
Bye, thank you.
Thanks, everybody. Bye.
Bye.
Mm.